Good afternoon, everyone. I am Nina Agbayani, Director of Programs at ACTRO. On behalf of ACTRO, I welcome you to the second in a five-part series of ACTRO's Practice Transformation webinars. ACTRO is a national association of 35 community health organizations dedicated to promoting advocacy, collaboration, and leadership that improves the health status and access of Asian Americans, Native Hawaiians, and other Pacific Islanders. With the rapid changes that are occurring within the healthcare landscape, we hope we can better serve Asian American, Native Hawaiian, and other Pacific Islanders serving community health centers with latest information on practice transformation. The goal of this series is to provide you with the latest on quality improvement, meaningful use, accountable care organizations, and patient-centered medical homes, and explain how they affect all of you and your clinics. In the last webinar of this series, we'll also be providing you with analysis of the culture and language access standards that we are seeing in these practice transformation efforts. Today's webinar is entitled Health Information Technology, Implications for Community Health Centers Serving Asian Americans, Native Hawaiians, and other Pacific Islanders, and our speaker is Ignatius Bao. Ignatius is a leader in health policy analysis, particularly around patient-centered care and healthcare reform. Prior to establishing his own consulting practice, Ignatius was a program officer and program director at the California Endowment, director of health policy and programs at the Asian and Pacific Islander Health Forum, and civil rights and immigration law attorney at the Lawyers Committee for Civil Rights of the San Francisco Bay Area. He was also part of the community efforts that resulted in the creation of the first White House initiative on Asian Americans and Pacific Islanders, and was a principal author on the first report from the President's Advisory Commission on Asian Americans and Pacific Islanders. Ignatius is a champion for the Asian American, Native Hawaiian, and Pacific Islander community, and a great ACTRO supporter and ally. We are honored to have him with us today for this five-part series. Today's agenda will include a 45-minute presentation and 15 minutes for Q&A. Today's agenda, before we get started, I wanted to review a few housekeeping items and let you know how you can participate in today's webinar. Here we are looking at an example. Hold on, I think we're having some technical difficulties. All right, looks like we're back on track. So before we get started, I wanted to review a few housekeeping items and let you know how you can participate in today's webinar. Here we are looking at an example of the GoToWebinar attendee interface, which is made up of two parts. The viewer window, shown here on the right, but maybe on the left of your screen, depending on your browser or computer operating system, allows you to see everything the presenter will share on their screen. The control panel, shown here on the left, but maybe on the right of your screen, allows you to participate in the webinar. By clicking the orange arrow button, you can hide or show your control panel. You can also set the control panel to auto-hide or not to auto-hide by going to the View menu. Please note that all attendees are on listen-only mode and will be muted during Ignatius' presentation. You may submit questions in writing during the presentation by typing them in the questions field. We will be reviewing questions as they come in and will address them during the Q&A session held after the presentation. Today's webinar is being recorded, and you will receive an email with a link to view a recording of today's presentation after the webinar. With that, I'll pass the meeting over to Ignatius.
Thanks, Nina, and welcome everybody to this second of our series of webinars on practice transformation for community health centers, particularly those serving medically underserved Asian Americans, Native Hawaiians, and other Pacific Islanders. So in today's webinar, what we're going to look at is how health information technologies can support quality improvement and practice transformation, and specifically how the HITECH Act that was passed in 2009 and the Affordable Care Act passed in 2010 support the widespread implementation and use of electronic health records as part of quality improvement and practice transformation efforts. And then we'll focus specifically on some implications for community health centers who are serving medically underserved Asian Americans, Native Hawaiians, and other Pacific Islanders. Last week, we talked a lot about the triple aim as a framework for quality improvement. And again, as a reminder, what the triple aim is talking about is that we need to improve access, which is really the patient experience of care. So even patients who are uninsured are eventually going to access some kind of health care, either at our community health centers or the emergency room or at the hospital. And so we really want to try to optimize and make their experience of care and their relationship with the healthcare system the best possible. We also talked about quality on the left-hand bottom side of the triangle, and that it isn't just about individual quality measures, but really improving the health of a community and a population at a community and public health level. And then finally, the third part of the triangle is, or the third aim, is reducing the cost of healthcare. And we talked about the inefficiency and waste in the current U.S. healthcare system and how we're not getting the kinds of results, the quality outcomes that we should be getting for the kinds of investments that we're making in healthcare. And so really part of the triple aim is also reducing the cost of healthcare overall as we're improving patient experience and improving population health. So how does health information technology fit into this triple aim, into the overall scheme of quality improvement and practice transformation? What we'll learn in this webinar, in the webinars to follow that focus on patient-centered medical homes and accountable care organizations, is that health information technology, and specifically electronic health records, are really at the core of any of these other kinds of quality improvement or practice transformation initiatives. That without the health information technology that comes with electronic health record systems, it's really impossible to try to implement some of the other kinds of more ambitious quality improvement and practice transformation activities. And so we wanted to start in this webinar to highlight how health information technology can really create the fundamental platform for this other quality improvement and practice transformation work. So in summary, what health information technology can do when properly implemented and used at its full functionality, what it will do is it will gather both demographic and clinical data electronically so that it can be sorted, it can be analyzed, it can be shared, both with patients and with other providers. It also really supports clinicians in their own decision-making with reminders and guidelines and best practices so that they can stay on top of the kinds of clinical guidelines that we talked about in the first webinar that unfortunately we're not always following. By having the information not just available in paper charts or on pieces of paper, but really in an electronic format, we can share that information for better coordination among providers. And last week in the quality improvement webinar, we talked about the importance of care coordination, especially across transitions of care when a patient is admitted to the hospital or when a patient needs to go to the emergency room or when a patient needs to access other kinds of services like rehabilitation services or skilled nursing facility services, that kind of information can continue to follow the patient and be shared with the primary care provider like a community health center. And then the other thing that I want to spend some time emphasizing in this webinar is it really also allows a greater degree of partnership and engagement with patients. And so in order for quality improvement to really take off, it's not just what providers can do, but it's also how patients themselves, as well as their families and caregivers, can be better informed, be better partners in their own self-management, in their own care. And so the electronic format of having that information accessible will make it easier for patients, families, and caregivers to be more engaged and more proactive in their own health care. And that really is a really critical point that I will come back to later on in the webinar. And so before we get to what happened in 2009 with the HITECH Act, what the landscape was and the environment was that it was very much dominated by the electronic health record vendors, and community health centers, like other providers, hospitals, physician practices, really had a lot of challenges trying to select and negotiate with these vendors who really had the power in this vendor-dominated market and didn't have a whole lot of choices. And so what happened was it was very difficult for community health centers to choose and implement, and it was very costly to make those decisions, and it was really, really a difficult challenge for many community health centers as well as hospitals and physician practices and other healthcare providers. But the important thing to know and remember about electronic health records and health information technology is that it really is more than just moving paper and medical records and charts into an electronic format. It really is a way, an entry point into these other kinds of healthcare practice transformations and quality improvements, and really redesigning how healthcare is actually delivered. And again, patient engagement is a critical part of that. So it really has to involve all staff, not just your clinical staff. It takes a lot of training and orientation. It takes a lot of support and patience. And there's going to be adaptations along the way, that whatever system you adopt and implement isn't going to be perfect and isn't going to work the first time. And so you're going to have to keep at it, and it's going to be a long process to get everybody on board, as well as to really understand and use all the functions that the electronic health record system can provide. And so really the turning point for making this much more realistic and accessible, even though still very, very challenging and difficult, was this HITECH Act that was part of the stimulus package in 2009 when the nation's economy was really sinking. Congress and the president came up with this $700+ billion stimulus package, for which about $30 billion was dedicated to the adoption and use of electronic health records. And the way that it was going to be designed was by getting the Centers for Medicare and Medicaid Services involved to use their leverage with Medicare providers and Medicaid providers to adopt health information technology, these electronic health records. So what the HITECH Act did in 2009 was it really empowered the Office of National Coordinator for Health Information Technology, which had already existed but didn't have a whole lot of influence or power, and certainly didn't have $30 billion to dispense, to establish policies and standards for the nation around electronic health records. ONC would certify records that met those standards that it determined were important baseline standards for all systems, and then worked with the Centers for Medicare and Medicaid Services to establish requirements for Medicaid and Medicare payments for the meaningful use of these ONC certified electronic health records. And so this is also a really important partnership within two parts of the Department of Health and Human Services, the Office of National Coordinator for HIT and the Centers for Medicare and Medicaid Services, to jointly administer this program that was created by the 2009 HITECH Act. So in order to gain these Medicaid and Medicare incentives, a Medicaid provider must use one of these Office of National Coordinator Certified Electronic Health Record Systems or modules. And if they adopt it, they are eligible for up to about $64,000 over a 6-year period through Medicaid. These are additional payments, and again, it's not going to cover the entire cost of the electronic health record system, or certainly not the cost of adoption, the time, the effort, the personnel costs that will be involved. So it really is an incentive payment to try to help those community health centers and other Medicaid providers in this particular instance adopt these electronic health records. The payment system is very confusing. The 6-year timetable depends on when you began the program. You gain the Medicaid incentive payments through your state Medicaid program, and so it's a little bit different in every state. But the important thing for community health centers is that physicians are eligible Medicaid providers for these payments, and so you should be able to gain these payments, and many of you at your community health centers have already received the first couple of years of these payments. But the HITECH Act also did other things besides these payments, again, which I want to come back and say are not enough for the full cost. They don't cover the full cost, but they are an important incentive to help people move in the direction of adopting these electronic health records. So the Office of National Coordinator also funded something called regional extension centers in every state, which really were charged with providing the technical assistance to eligible providers and hospitals, particularly and also including community health centers. The Office of National Coordinator also funded infrastructure to support the exchange of health information among providers using their electronic health records. And so again, if the whole point is to be able to take information about your particular patient and share it with a hospital or a specialist or another provider, and similarly for hospitals and specialists to share information about your patient with you, then you need some sort of infrastructure that goes beyond the individual electronic health record systems at each provider to support that health information exchange. There were also some workforce and innovation grants, and now the Office of National Coordinator is really looking at the second generation of this body of work of how it continues to support technical assistance and that health information exchange. And so for federally qualified health centers and other community health centers, the regional extension centers in every state were charged with finding and helping FQHCs and community health centers. And in most of the states, it's a little obscured, that most of the HRSA-funded FQHCs and lookalikes were actually enrolled within regional extension centers. So nearly 83%, over 83% were actually receiving assistance from the regional extension centers. And so again, many of you benefited from the technical assistance from those regional extension centers in implementing your electronic health record systems. So then going back to this slide about on a pragmatic level, once you decide that you're going to adopt an electronic health record and maybe get technical assistance from a regional extension center in adopting and choosing even which system to adopt, how is this actually going to make a difference? And so what the Office of National Coordinator and the Centers for Medicare and Medicaid Services came up with was really a 3-stage process of increasing the requirements of how to use that electronic health record system. Stage 1 was really focused on using the electronic health record to do that electronic capturing and recording and documentation of both demographic and clinical data so that it could be shared. The stage 2 that we're now in, that really began in 2015, earlier this year, again, depending on where you are in that 6-year timeline of getting incentive payments, that for the early adopters, you're now required to be doing stage 2, and that requires using the electronic record to support your clinical decision-making, your patient engagement, and sharing your information about your patients with other providers. And in stage 3, the proposed rules for stage 3 were just published, and we'll come back to that shortly, and they won't go into effect until 2017, but it really is using all the functionality of the electronic health records to actually get to improved outcomes, to improve patient engagement, and improve quality through the support of the electronic health record. So I'm going to go through some of the stage 2 requirements. Some of you, depending again where you are on that 6-year timeline for the Medicaid incentives, are still under stage 1 requirements, but eventually, beginning this year, everybody will eventually have to meet these stage 2 requirements. And so the first thing is exactly what stage 1 was focused on, which was recording demographic data and clinical data like vital signs, but also something like smoking status. And so in stage 1, these requirements were at 50% of your unique patients. In stage 2, you're going to essentially need to do all your patients by getting up to an 80% level of recording this kind of information for your patients in the electronic health record so that, again, you can retrieve it and use it. And then secondly, really supporting the processes of care, so something like prescriptions. So rather than writing out a paper prescription and handing it to your patient to go fill at either your pharmacy inside your clinic or a pharmacy outside your clinic, that those prescriptions will actually be generated and sent electronically so that the pharmacist will actually have the prescription and hopefully have it ready, the medication ready for your patient when they even show up at the pharmacy. Using then the electronic prescription and medication information to do reconciliation so that one of the real problems that we talked about last webinar was when patients are discharged from the hospital, oftentimes they don't understand what medication they're supposed to take, what new medication they're supposed to take, what old medication when they were first admitted to the hospital they should stop taking. So again, having all that information in an electronic format allows a hospital and a primary care provider to do that electronic reconciliation and make it clear to the patient what medication they should be taking from now on. And then similar to medication orders and prescriptions being sent electronically, we want to encourage lab and imaging orders, so blood tests, x-rays, MRI, CT scans to be ordered electronically. And so again, you're keeping track of whether or not those tests have actually been done, and hopefully you'll even get those tests back electronically. It's still a fairly low threshold for the lab and imaging orders. It's only 30%, but we want to start moving out that kind of interaction to be much more electronic and automated through the electronic health records. So again, at least for the lab results, to actually get the results back incorporated into the electronic health record, not as a scan, not as a fax, but actually showing the blood results, for example, the blood test results in a structured way so that you can pull that up automatically when you see your patient the next time, that you see their lab results immediately in their electronic health record. Then the next thing is using the electronic health record now that you have this clinical data and you're getting updated test results, you're getting results from transitions of care, you're getting medication results. So you can also be generating lists. Who are all my patients that I'm seeing who have diabetes, and how are they doing? Are all their lab results up to date? Should I be sending out reminders for someone who I haven't seen in a year to go get an updated A1C test, and making sure that they are called back in and see me as a provider to make sure that their A1C levels are still under control and that their medication regimen is still up to date. Using electronic messaging to communicate with patients, so not just sending them reminders, but also being able to answer questions, sending electronic messages among providers. So if I have a question about whether or not a lab is being duplicated, that I can communicate electronically with that lab or that other provider. And then also, again, a fairly low threshold in terms of quality improvement. If I have a patient with diabetes, am I providing that patient with really good health information about their diabetes? Am I providing them resources that helps them manage their diabetes, refer them to maybe a nutrition class or to some sort of physical activity that will help their diabetes? And so again, those resources should be generated and prompted automatically out of the electronic health record, because the electronic health record tells me that this patient that I'm seeing, Mrs. Chan, has diabetes, that maybe they're not doing so well in terms of their A1C levels, and I might be encouraging Mrs. Chan to go to a Tai Chi class to help with physical activity, to get a little more movement, or to a nutrition class at a local Chinese cooking school, so that she learns some better nutrition and cooking techniques to help control her diabetes. And then finally, from a clinician point of view, that clinical decision support. So again, using the diabetes example, am I making sure that Mrs. Chan, my patient, is having her annual foot exam and her annual eye exam, and those kinds of reminders that otherwise, if I haven't seen Mrs. Chan for a while, I may not remember the last time that she got those exams, but the electronic health record would prompt me and remind me that those are things that are in guidance and in best practice guidelines, and so I should be paying attention to whether or not Mrs. Chan is up to date on those kinds of screenings. And then the really important thing, the first step in sharing information with patients and families and caregivers, is that every time Mrs. Chan comes in to see me, I should be leaving with her a summary of, these are the things that I recommend, this is your A1C test, here are some goals for maybe lowering it the next time that I see you, and so that she and her family and her caregivers also really are on the same page, literally, of not just what I know as a clinician, but that she's also tracking those results along with me and has clear goals in her care plan about how to improve her own health. The ability to do that not just when patients come into the clinic to see you, but also eventually through patient portals to be able to do that in a continuous way. Again, the threshold for stage 2 is very low. It's only 5% of having patients go into the patient portal and look at their information when they haven't actually come into the community health center or clinic to see you. But eventually we want to give patients essentially the same access to almost all the information, to their lab results, to their imaging results, to their medication lists, to their diagnosis and problem and disease lists that you are having as a clinician. And then clearly, one of the other requirements, never forgetting the importance of the security and privacy issues, making sure that your electronic health record, and this is a requirement for all the certified electronic health records, is taking steps to protect that information and respond to any breaches that might happen. And then finally, sharing the information not just with your patients but other providers, especially during transitions of care, and then from a public health and the population health improvement standpoint, submitting some of that information electronically, and starting with something like immunizations to electronic immunization registries. There are some additional requirements that are optional requirements, and this, again, is starting to look at the other functionalities of the electronic health record. So recording information about family history as part of a more comprehensive health assessment. And this gets you to know what other risk factors might be relevant for other diseases that you might not be currently diagnosing that patient with, but begins to ask. So as somebody turns to the age where they're going to need to look at a colon screening, if there's a history of colon cancer in the family, that might make you pay a little more attention to that screening and be a little more aggressive in what you might recommend for that screening, knowing that family history. The same thing with some of the cancer screenings, that again, if you know that there's a family history of cancer, you might be a little more aggressive and proactive in encouraging more cancer screening for that particular patient. We want to continue to incorporate clinician notes in the electronic health record, and we eventually want imaging results similar to electronic prescription and lab results to also be in the electronic health record. And then finally, from the public health perspective, we want to go beyond immunization data and actually start reporting cancer screening data and other kinds of data to public health authorities that, again, will help us to look at things from a population health point of view. So again, these are all stage 2 requirements that either are in effect now for you or will become effective. And these are all examples of how, from reporting the clinical data to using the clinical data to sharing that clinical data with other providers and with patients, that increases their engagement and helps you do quality improvement in a more systematic way. Stage 3, as I mentioned, has just been published, and comments on stage 3 requirements are going to be due in May. The important takeaway for stage 3 requirements is that any implementation won't happen until 2017, and so there'll still be some time. We expect that the actual requirements would be finalized in a final rule later on this year, which will give plenty of time for the electronic health record vendors to adjust and make sure that their functionality will support the stage 3 requirements. So we expect, in summary, that there will be much more requirements to do health information exchange. So imaging, lab results, medication will be expected at much higher percentages of thresholds, much more information sharing with patients, as well as with other providers and during transitions of care. So again, expectations, for example, that hospitals on their side of their requirements will actually be sharing both admissions data as well as discharge data with primary care providers like those of you in community health centers. So again, the requirements go in every direction, not just what you need to share as a primary care provider, but what hospitals are going to be sharing with you. You're going to be expected and required to use the electronic health record to do more reporting of your quality data and demonstrate how you're using the electronic health records through things like clinical decision support and patient reminders and other prompts to demonstrate actual quality improvement. And part of the stage 3 requirements will be for you to be looking at specific quality improvement activities that you'll be undertaking and demonstrating that you've achieved those kinds of quality improvement. So again, not just recording the information, but actually using the information in a much more sophisticated way, both at an individual level and a population level. And then finally, much more patient sharing of information and engagement. So more requirements around patient portals and making information accessible, and more requirements about using the electronic health record, for example, to provide tailored patient education and engagement information for patients, particularly for Asian American, Native Hawaiian, and Pacific Islander patients. We would want to see those patient engagement and patient education tools in language. And again, that's going to be a continuing challenge to work with electronic health record vendors to making sure that they have the capability to provide that kind of material in a way that is language and culturally appropriate for the patients that we're seeing. So the good news is, with these incentive payments, as well as the push from the federal government to adopt electronic health records, we have seen a dramatic increase in the use of electronic health records among federally qualified health centers. And this just shows that growth over time, that eventually we'll get close, pretty close to that 100% mark, because this data is already a little bit outdated. The important thing on this slide, though, is that we're still a long way from the full functionality and the full use of electronic health records. The green is that the electronic health records meet all, even the stage 1 requirements, and that's still a minority of all those that have begun to implement electronic health records. So we're still not at the point of full functionality and fully meeting even the stage 1 requirements, let alone the stage 2 and eventually the stage 3 requirements. So as I said at the beginning, it's not an end point. It really is a beginning of a process of adopting the electronic health records and then making sure that you're having all the functionality that meets the meaningful use requirements, stage 1, stage 2, and eventually stage 3. So what are the specific implications for community health centers that are serving Asian Americans, Native Hawaiians, and Pacific Islanders? We have to recognize that every community health center is at a different stage, but that you should continue using whatever technical assistance resources. If your regional extension center is continuing to offer those technical assistance resources, you should continue using them. And you should be doing everything you can to maintain the eligibility to meet the stage 2 and eventually stage 3 requirements so that you get the full $65,000 Medicaid incentive payments that you're eligible for, because that's going to help you with some of the cost of implementation. So that's the first step, to take advantage of those resources, both technical assistance and financial, in terms of the incentive payments. But moving forward, then you should be thinking about where the whole point of adopting health information technology is, which is exchanging it with others. And so in local communities, some of it is very local and regional, some of it is statewide. There are infrastructures that have been created for health information exchange. So as a community health center or as a consortium of community health centers, you should be paying attention to who's supporting that, what the fees for participating in that health information exchange might be, and how to make sure that information from community health centers is included in that health information exchange. ACTCHO, in the time being, will continue to be functioning as a national data warehouse for its own members and continuing to collect and analyze some of the data that its members are collecting through their electronic health records. And in the latest issue of Nexus that was published by UCLA, ACTCHO continues to share some of the findings from that national data warehouse and the efforts that some of its members have had in implementing electronic health records, in implementing patient portals, in really using the electronic health records for quality improvement. And so anything that comes from ACTCHO members and that ACTCHO is able to gather and disseminate will also help the rest of you who are still in the early stages of implementing electronic health records learn from what you can do with your electronic health record and how to optimize its functionality and use. And so here's an example that was an early results from some of the ACTCHO data warehouse work that it had done, particularly with community health centers in Hawaii. I want to then shift gears to a quick preview in some ways of where we're going for the next couple of webinars. As I said, electronic health records and health information technology is really a platform for a lot of the work that is eventually going to come about through healthcare reform. And so one of the things that, back to this slide, we're going to talk about in subsequent webinars are this idea of patient-centered medical homes, which really depend on your ability to collect the information from your patients and about your patients in electronic health records and then share it with other providers. And so it's going to be very difficult to become a patient-centered medical home, and we'll talk about this in the next webinar, without having a fully functioning electronic health record. And then similarly, when we talk about accountable care organizations and some payment reform models that are being implemented, again, you're not going to be able to really participate in those accountable care organizations or any kind of payment reform if you're not using electronic health records. And so the important thing is to think about these things as building blocks and in sequence. I love the title of this publication from the Agency for Healthcare Research Equality, that electronic health information and health information technology is necessary, but it's not sufficient for medical homes. And it's part of the building blocks for getting to become a medical home. And so it really is, again, important for us to be thinking about how to use the health information technology and electronic health records now as we look forward to these other kinds of initiatives for quality improvement and practice transformation. I think particularly for medically underserved Asian Americans, Native Hawaiians, and Pacific Islanders, and other racial and ethnic minorities, limited English proficient patients, patients who have challenges with health literacy, low-income patients, uninsured patients, there's also great potential to use the health information technology to do what I call leapfrog over some of those disparities. And one example would be that many times we have challenges communicating with patients because the traditional ways that we use to communicate through telephone and mail doesn't work for patients who are mobile, who don't have fixed addresses, who move around a lot, who don't necessarily have income so that sometimes their utilities get cut off, who might be homeless. And so the irony is many of those individuals actually have mobile phones. And so they may not have a landline at their home, they may not have a stable home environment, but they still carry their mobile phone around. So if we can use the mobile phone that is literally already in their hand to send them text messages, to send them reminders, to do other kinds of patient engagement, we actually might be more effective in reaching them. And this is certainly true. There's a lot of data and a lot of evidence now for African American and Latino patients who actually use mobile phones much more to access the internet than white and Asian and Pacific Islander populations, that there's lots of innovation and creativity to, again, as I said, leapfrog over those other communication barriers and really engage those individuals in a much more meaningful and effective way. And so similarly, we've had lots of challenges, especially at our community health centers, in communicating in the multiple languages. But again, if health information technology can help us translate, have readily available materials that are in language, in multiple languages, readily accessible so that we're not running over to the file room or we're not looking and hunting for where is that Cambodian language information sheet on diabetes, we can just pull it up out of the electronic health record. That's also going to help us. I think there's going to be real challenges in patient portals in being able to communicate with our patients in multiple Asian and Pacific Islander languages. But again, the internet is international and global, and people are able to use the internet in multiple languages. So really applying the best of that technology in our electronic health records and in our patient portals is something that can also really facilitate that communication. It's a challenge for us to do and implement at this point, and many electronic health records don't have that functionality or capability, but it's something that, again, we can continue to look forward to the technology really being an answer, a solution to some of these other issues that have been barriers. Health literacy is another really, really important thing, and again, we often struggle with having information that's available to our patients who have health literacy challenges. But again, if we have the patient education material in our electronic health record and easily pulled up and accessible in the electronic health record, either to print out when our patient is in our community health center or clinic, seeing us in a patient encounter, or sending it to them electronically in some format, having information that is at appropriate health literacy levels, vetted and readily available, and again, having that readily available so that we're not hunting or worried about whether or not it's appropriate to send will also help address that particular challenge. And then finally, another way that in a family or in a caregiving situation where different people have different familiarity and access to technology, a classic situation would be an adult child who speaks English and is much more acculturated, helping their older parent navigate the healthcare system. And we see this often in our community health centers. And so if that Vietnamese child is helping their elderly Vietnamese parent, maybe that Vietnamese American child who is an adult can receive a text message about their parent's next appointment at your community health center, but your community health center will also send a patient reminder by triggering an automated phone call in Vietnamese to that elderly patient at home. And it's, again, the technology will allow that reminder to be sent in both formats, one in language by phone and another in English by text. And it's, again, automated. It's not something that you have to think about. If that appointment is coming up next Monday, that reminder goes out on Friday automatically. The clinician isn't even thinking about it. It's just set up to go out that way. And those preferences are already in the electronic health record for that particular Vietnamese elderly patient. And so that's another way that the technology can help both the patient engagement and the information sharing, but also help the clinician with things like no-shows and other kinds of things that are often challenges in our community health centers. And so this article is by Quinn Metzger and her colleagues, where she really looked at how, in particular Asian American context, some of this technology was being used, and she wasn't able to find a whole lot of examples way back in 2010. And hopefully with the community health centers implementing electronic health records and health information technology in the last couple of years, we're eventually going to have more and more of these examples. And again, in the recent Nexus edition that was published by UCLA, there are actually some really great articles and examples of how that's being done among the actual members. So in summary, some of the ways in which community health centers serving medically underserved Asian Americans, Native Hawaiians, and Pacific Islanders might use the health information technology to engage those patients are through multilingual messages, by bridging the digital divide through things like text messages, using not only what we call e-health, but what we call m-health, the mobile health technology, using mobile phones. And then lastly, that many of us are on social media, and so as we think about ways to improve and increase patient engagement, there might be a local cancer support group that we can use social media to get the word out for patients who have cancer and their family members, or a local diabetes group that is working on diabetes education, that these are ways in which social media can be a real useful tool. We know that in the Asian American community in particular, the successful efforts that we've had about raising awareness around hepatitis B screening, particularly for Asian Americans and others, has really used social media and these kinds of tools, and again, incorporating them into our electronic health records, incorporating them into how we think about health information technology and communications technology overall is also something that is really, really important. And so ultimately, what we want the electronic health records and health information technology to do is really facilitate and share health information among patients, families, and healthcare and caregivers, as well as other healthcare providers, and really provide patients as well as their families and caregivers and all their other providers with the tools to use the information in an electronic format to better manage and improve their health. And so this is, again, the promise. We are a long way off, as we said, from getting the kinds of systems, electronic health record systems with the functionality to be able to do all this. And it's a long process to actually implement within a community health center to get them to the stage in which they can actually achieve all of these kinds of goals and objectives. We're going to stop. But I did want to remind you that we are going to focus then, we're going to skip next week, but on April 22nd, on how community health centers can use a patient-centered medical home model to support their quality improvement and practice transformation activities. And then we're going to talk a little bit about payment reform and accountable care organizations, and then conclude in the first week of May around culturally and linguistically appropriate services and how we can pay attention to class standards as we're implementing quality improvement and practice transformation activities. But on that note, I will end and open it up for questions.
Thank you, Ignatius, for this great overview of how health information technology supports quality improvement, how to use electronic health records supported by HITECH Act and Affordable Care Act, and sharing implications for community health centers serving Asian Americans, Native Hawaiians, and Pacific Islanders. We will now begin the question and answer section of our call. As mentioned at the beginning of the call, we will start by answering questions submitted to us via the chat function. If you would like to submit a question now, please do so in the chat box on the right-hand column of your GoToMeeting screen. Ignatius, here's the first question. This question is in regards to protection of patient health information. Do health plans have access to lab reports, x-ray findings, diagnosis results, or only claims information?
So right now, health plans, and so many of you are working with health plans for Medicaid, and some of you are participating in the state health insurance exchanges and marketplaces in which you're now contracting with commercial health plans who receive their health insurance through those health insurance marketplaces. The health plans don't have any automatic access to the actual lab results, the clinical data that a lab or so either test results or imaging results. But eventually, if there is health information exchange in your local area, we would want the health plans to also have access to that, again, at a population level, so that they could be aggregating and looking for anomalies, looking for patterns, actually also helping you as providers to see if there's a lab that's problematic in terms of its turnaround time. So those are all ways in which, back to the overall sense of efficiency, that we want to reward the providers across the healthcare system that are doing a good job, and we want to try to eliminate the inefficiencies and waste in the system. And so if a lab, for example, is always late in returning results or doesn't do the results well, then maybe that health insurance plan doesn't want to contract with them anymore or pay those claims anymore. And that's, again, a good thing for the overall reduction in cost, but also the turnaround time and the efficiency of the healthcare that you'll provide. So again, it's not automatic, but it would be the kind of thing that would be supported through health information exchange.
All right, thank you. And the next question is, do you have recommendations on how to communicate to patients the importance of HIT and why there might be some bumps along the road that are impacting their experience at the clinic?
Sure. So for all those community health centers that have already started implementing electronic health records, you know that it's a really, really difficult, challenging, and painful process, that you're going to have lots of grumbling from your staff. You're going to have some inefficiencies initially in the number of patients that you're going to be able to see. There are going to be some of your providers that will take to the technology really easily, and then especially some of the older providers are really, really going to struggle with it. So I think as you're going through that process, explaining first the transformation process to your patients and asking for their patience with your providers, who are often going to be stressed and frustrated and experiencing some of those technical challenges and difficulties. And then I think for some patients who are used to using technology and familiar with the technology, they're going to love it. They're going to want to immediately use functions like electronic appointment making and filling out and following up on their prescription medications electronically. And then the others, especially older patients or patients who don't speak English as a first language or don't have reliable internet access, digital divide issues are still very real. It's going to be a challenge for them to, if you are saying, I'm sending the prescription electronically to a pharmacist, they may not understand what that means, and they're saying, where's my paper prescription? I'm used to having that little piece of paper that I'm going to take to the pharmacist. So I think it's going to be different both on the provider side and the patient side, what the challenges are. And again, as any practice transformation, you have to do a lot of continuous education. You have to do a lot of adaptation. We talked in the quality improvement webinar last week about this notion of these plan, do, study, act cycles, these rapid change and quality improvement cycles that you have to test things out, see how they're working, and be ready to make adaptations as you go along, both with your providers and with your patients.
Thank you. The next question is, isn't it a challenge to extract EHR data? I was told that EHRs can vary, plus the data entry formats are not uniform.
Right, so if you're having trouble extracting the data from your own EHR, you should really think about getting a new vendor or a better vendor or better technical assistance, because that's the frustration. You shouldn't be having. The EHR that you have adopted in your community health center should be able to provide you, for example, a list of all your patients with diabetes and all their lab results that you have entered electronically so that you can look at them as a whole. And so you're not scrambling and asking your medical assistant or your medical records person to gather up all those records and go through them by hand. That's a click of a button that you should be able to pull up all those diagnosis codes, pull up the panel of patients, and then pull up their lab results. And that's, again, a basic functionality that if they're a certified product, you should be able to do. The challenge is, how do you share that information with a hospital? How do you share it with a specialist? How do you even share that information for even across your clinic with your oral health providers, with your dentist? So again, that sharing of information outside of your own electronic health information system is going to be an ongoing challenge, and that's where health information exchange comes in. And again, it's very different in different parts of the country, but eventually what we really want to do is to be able to have that functionality. And just my editorial comment is, just as we're increasingly getting used to storing documents in the cloud, so either through some commercial service or free service, that ultimately is the way that this data is going to be stored, that it's not going to be necessarily somebody accessing the information from your electronic health record, but your electronic health record uploading the relevant information into the cloud, and then having somebody else with permission access that information in the cloud. And similarly, you then also accessing information in the cloud, and the cloud would then aggregate that information for that particular patient all together.
Okay, thank you. And we have one more question. Some folks might not have access to text, email, and phone. How can we ensure that they still have access to the benefits that health IT offers?
So, as I said, we have to recognize that there are going to be digital divide issues. Again, there's also cost issues. There's broadband capability issues in rural areas that we need to recognize, as well as the other limitations of just accessing and using technology. So again, I think we have to pay attention and always allow defaults to old school systems of telephone calls and mail and printing things out and sharing things with people by paper. But I have continually been surprised at how much people actually have access to, especially mobile telephone technology, and the costs continue to go down, data plans continue to go down, and people are also able to use public libraries and other access points. We also want to promote things like free Wi-Fi access and free broadband. Many municipalities and cities are starting to offer free Wi-Fi access. And so again, I think all those developments are going to help us move, giving greater access to the technology, and then greater access to the health information through the technology. But we do have to pay attention and ask our patients whether or not they have access and whether or not they're familiar with it. And if they're not, then to default to those other systems and other ways of communication.
Thank you, Ignatius. This concludes the Q&A session of this webinar. We wanted to apologize for the lag in slide showing earlier, and we'll be sending out the entire presentation after the webinar. Before we hang up, I want to remind you all that if you have not done so already, there is still time to register for our next webinar, which will be on Wednesday, April 22nd at 12 p.m. Pacific Standard Time. This next webinar will focus on patient-centered medical homes and its implications for community health centers serving Asian Americans, Native Hawaiians, and other Pacific Islanders. Register for this webinar at www.apshow.org. For those of you who have already registered, thank you, and we look forward to speaking with you during our next webinar. Goodbye.